So we have arrived at almost the end, and it is my great pleasure to introduce our closing speaker for the day. Our closing speaker is the Honourable Dr. Jane Philpott, whose story will be familiar to many in this room. Dr. Philpott is a physician and former Member of Parliament, where she held the post of Federal Minister of Health. Prior to politics, Dr. Philpott worked as a family physician for 30 years, spending the first decade of her career in Niger, West Africa, where she practiced general medicine and developed a training program for village health workers. Since resigning from Cabinet, she has been volunteering as an advisor for Nishnawbe Aski Nation, and starting July 1st, will become Dean of the Faculty of Health Sciences at Queen's University. In her free time, Dr. Philpott's favorite place to be is with her family, reading and relaxing on the shores of Big Rideau Lake in eastern Ontario. In her closing comment and closing keynote, she will share her thoughts on the Canada Health Act and reflect on her experiences as Minister of Health in a talk entitled, "The Canada Health Act, Fold, Hold, or Raise." Please welcome Dr. Philpott.
Thank you very much, Karen, for the introduction, and good morning to everyone. It's nice to see you. I'm really happy to be here with you and to have spent a few days together on unceded Coast Salish territory. I want to thank you for all of the things that you've taught me over the last day or so, and especially to Karen and Michael for organizing such a great conference. It's always really fun to be surrounded by people who know and love health policy as much as I do, who think a lot about health systems, and specifically people who care about the Canada Health Act. So I've been asked to tell you a bit about my journey as Minister of Health, the minister who is responsible for upholding and enforcing the Canada Health Act. And I hope to give you a bit of a behind-the-scenes perspective that will be valuable to you and to add to the conversation that we've already had on the topic of private parts. So the look behind the scenes from the perspective of the health minister will comprise the bulk of my presentation today, but I'm going to spend a few minutes at the end thinking about what's missing in the Canada Health Act and make a few comments on the importance of the work that you do as both academics and advocates. So I was in a unique position when I became Federal Minister of Health in 2015. I was the first physician to hold that exact position. Now, to be technical, there were two previous physicians who held similar roles when it had a different name. There was Dr. James King for 2 years and a Dr. Donald Sutherland for 1 year, who were each Minister of Pensions and National Health in the 1920s and 1930s, respectively. But it had been a long time since a doctor had been in that role. So my health background came with a lot of advantages. I had studied the Canada Health Act, I had served as a physician guided by its principles, and I was convinced beyond a shadow of a doubt that the success of Canada's health systems relied on maintaining its foundational principles, such as access to care, which is based on medical need and not based on either the willingness or the ability to pay. It's a truly exceptional piece of legislation, and I will be forever grateful to the smart and caring people that brought the Canada Health Act into law in 1984. As you may know, Monique Bégin was the Federal Minister of Health at the time. Monique became a friend of mine in the last few years, and we would get together for dinner periodically. She's still as smart as ever and as thoughtful as ever. I just finished reading her very recently published memoir, which is entitled Ladies Upstairs, referring to how she was treated as one of Canada's first female cabinet ministers. I encourage you to read it, especially the really interesting chapter on the Canada Health Act. Now, I must confess, as I was reading Monique's memoir, I was kind of embarrassed to reflect on how little awareness I had had as a medical student in the early 1980s when all of this was happening. I was not adequately aware, I don't think, of the chaos that was unraveling in Canada's universal healthcare landscape. Those were really the Wild West days of extra billing and user fees. Somehow I must have been focusing on anatomy or pharmacology or some other important thing and not paying a whole lot of attention to the federal and provincial health policy debates that were taking place, apart from a bit of a general public awareness that everyone in Canada had at that time of the constant threat of doctors' strikes. And as you read Monique's reflections, you realize what a miracle it is, in a way, that in spite of an extraordinary amount of opposition, they eventually, with all party support and with the help of some really fantastic advocates, including in particular a shout out to organized nursing, the bill was passed. And because of that, the inimitable Monique Bégin will always be a Canadian hero in my eyes. So let's fast forward to 2015. The Canada Health Act was, I believe, under threat, as it has been for some time perhaps, in various ways. And by that time, I did fully understand the implications. I felt a huge burden to ensure that under my tenure, the Act would be administered in all of its fullness and would not be weakened through either ignorance or neglect, willful or otherwise. It's been good to see in recent weeks that with the closing statements of the Cambie case, there's been a little bit of media attention to the matter, particularly through the mechanism, for example, of opinion pieces that have appeared in some national media organizations. But it's my sense that in general, Canadians don't pay a whole lot of attention to the Canada Health Act. And it's also been my impression that politicians are largely happy to keep it that way. And I think that this is one of those examples where, if I can paraphrase a little bit the words of Martin Luther King, time itself becomes an ally of the forces of political stagnation. So I've been asked to share with you what happens behind the scenes. You'll be interested in hearing that, in fact, under my tenure at least, there was considerable discussion about the Canada Health Act in ministers' offices. Some of that discussion I'm not entirely at liberty to share in detail, but I can tell you quite a bit about things that are already in the public domain and hopefully fill in a few missing pieces and lesser-known facts. I think the real beauty of the Canada Health Act lies in its simplicity. As you know, and we've discussed over the last day or so, it lays down a series of criteria or conditions for how healthcare services have to be provided by provinces and territories in order that they would get a full Canada Health transfer. And the enforcement mechanism, therefore, is also, in theory, simple. As you may know, it has two parts. First, if the federal government is, quote, of the opinion that the healthcare insurance plan of a particular province or territory does not satisfy any one of the Act's criteria, the federal government can impose a discretionary penalty, reducing the Canada Health transfer by an amount that's deemed appropriate given the gravity of the default. What you may not know is that to date, these discretionary penalties have never been applied. The penalties you may be more familiar with are those that are on specific violations around extra billing and user fees. These penalties are theoretically mandatory and automatic. And the Act specifies that the deduction from the Canada Health transfer must be equivalent, dollar for dollar, to the total amount of extra billing or user fees. Now, thankfully, the minister is not on his or her own in terms of determining whether or not there have been any breaches. There is a part of Health Canada that's been referred to already. It's called the Canada Health Act Division, and we have a couple of staff, wherever they are hiding at the moment, from the Canada Health Act Division. Maybe they don't want to be pointed to, but, oh, there they are right in front of me. Yay, Chad! The Canada Health Act Division. Okay, they do cool work and nobody really pays much attention to them, but man, they hold up the system. So their responsibilities are to monitor provincial and territorial compliance with the requirements of the Act, and they are to inform the federal minister of possible non-compliance and recommend potential actions to correct the situation. So here's where things get a bit tricky. The monitoring is not easy. It relies on people like our friends here scanning the media, following up on correspondence and public complaints. They follow up with provinces and territories as situations arise, and they try to very quietly settle things in the background before the issue of deductions comes up. Unfortunately, Health Canada has no authority to actually investigate under the Act directly, but it is the role of provinces to carry out those investigations. And then each province or territory is supposed to, in December of every year, file financial statements to Health Canada itemizing the extra billing and user fees that have been discovered or reported, and they're supposed to also state whether or not patients have been reimbursed for those. If nothing is received, as is sometimes the case from a particular province or territory, and if the minister has reason to believe that the information is incomplete or inaccurate, then the minister is expected to estimate any potential deduction that is required, but must consult with the province or territory before doing so. So right from the start of my mandate as health minister, I knew that non-compliance with the Act was an issue that I would have to take action on. Of course, at that time, the public face of what our government was doing and what Health Canada was specifically doing was things like negotiating a health accord with provinces and territories and working with our colleagues under pressure to enact legislation under a Supreme Court deadline around medical assistance in dying. But behind the scenes all this time, there was a lot of conversation taking place with my deputy, with senior officials, and with members of my minister's office regarding this issue of Canada Health Act non-compliance. And in particular, a few different situations. The ones I'm going to talk about are British Columbia, Quebec, and Saskatchewan. And so right from the start, I began signaling in speeches that I was giving, dropping hints. There's always hints in speeches, so you have to look for those. So I was dropping hints about how important I felt the Canada Health Act was, and when I met with my provincial and territorial counterparts, I made sure I reminded them on every occasion about my firm commitment to enforce the Canada Health Act. I had good reason to believe that there was significant, that the magnitude of non-compliance, particularly in British Columbia and in Quebec, was much greater than the amounts that either of those provinces had been reporting for a number of years. And I was determined under my tenure that I would not turn a blind eye to these matters. Among other reasons, I knew that there was a very important case taking place in the Supreme Court of British Columbia that would be affected by how seriously the federal government took its obligations under the Act. And so one of my very first decisions and actions on this file was to speak to the former federal attorney general, who just happens to be with us in the room today. And so I just want to introduce and give a shout out to my very good friend Jody Wilson-Raybould, who I think is probably pretty well known to you for reasons maybe other than the Canada Health Act, but maybe for single-handedly upholding the rule of law in the biggest corporate criminal trial in the country, but other than that, a few other things she's done. So I'm happy to report that when I spoke to the former AG, she understood immediately. And so by the spring of 2016, as BJ spoke about yesterday, Ottawa had a formal role in the trial. Because the enforcement mechanisms for breaches of the Act have significant fiscal implications for provinces and territories, you might be able to imagine that any discussion has a very significant impact on intergovernmental relationships. And so there's actually not a lot of political incentive to draw attention to these contentious issues, and at least in a public manner. So what we did was we started in 2016, then we had a federal, provincial, territorial, or FPT health ministers meeting, and as you might imagine, one of the biggest items on the agenda was not the Canada Health Act, but was the fact that we were trying to negotiate a long-term funding agreement with provinces and territories, and the only thing that provinces and territories wanted to talk about publicly that year was how they needed so much more money from the federal government in their transfer. So for several reasons, it was not the right time, at least in the public's eye, to play a heavy hand with clawbacks on the transfer. But what did happen, starting particularly in March of that year, was important private communication that took place in the form of phone calls to my friendly colleagues and letters to provincial ministers in which I let my concerns be known. But thankfully, other forces were also at play. As you may recall, Quebec had passed legislation in November of 2015 that would actually have entrenched user fees, regulating their amount using a standard list for private payments. And then a little bit after that, on May the 3rd, 2016, Quebec lawyer Jean-Pierre Ménard announced a lawsuit against the federal government. And Ménard was acting on behalf of Réseau FEDOC, which was formerly known as the La Fédération de l'Âge d'Or du Québec, the Golden Agers of Quebec, and its 450,000 members. And the lawsuit was in an effort to force me, the federal minister, to apply the Canada Health Act not only in Quebec but other provinces as well. It was brilliant, and I was quietly very happy. Particularly because this litigation brought evidence of the magnitude of the problem in Quebec. And he stated in the suit that extra billing and user fees for things like vaccinations and eye drops and other procedures was in the order of $50 to $70 million per year in Quebec. Even more helpful still, that same month, the Auditor General of Quebec tabled a report that documented the extent of user fees in her province. And she reported that Quebecers were facing add-on fees for things like up to $400 additional for every colonoscopy, up to $225 additional for every vasectomy. Those were just some of the examples in her report, and she estimated that the total per year was up to $18 million. This was just the kind of evidence that I needed, because as you'll recall, the federal minister, if he or she believes that the information that's provided by the provinces and territories is incomplete or inaccurate, is expected to estimate a potential deduction, but is also required to consult with the provinces and territories. So anything that I had on hand that would provide evidence of the magnitude of the problem was beneficial. So we were facing litigation on the matter. I needed to write to the provincial ministers, and particularly the provincial minister in Quebec, to demonstrate that the federal government took these matters very seriously. And so on September the 6th, 2016, I sent a letter to Quebec Health Minister Gaétan Barrette, noting that the report of the Provincial Auditor General confirmed the presence of extra billing and user charges in Quebec. And I asked him to report data about the costs that were being paid by the people of Quebec, and informed him that I intended to enforce the Canada Health Act by retaining a portion of the Canada Health transfer. I also asked for an immediate end to the practice of extra billing and user fees. And normally I might not be able to share a letter like that, and I'm not actually sure how it became public, but Monsieur Ménard happened to get a hold of the letter, and it's published with a link on his website, even to this day. So, much to my delight, at a press conference just over a week later, on September the 14th, 2016, Minister Barrette announced the abolition of les frais accessoires, accessory fees, and he said that the decision illustrated the government's commitment to guaranteed access in the healthcare system. Now, interestingly, when Monsieur Barrette on that day was asked whether user fees weren't already illegal, he said, well, if they were, the federal government would have intervened earlier. But at any rate, when asked whether the decision had anything to do with the federal government or anything to do with Monsieur Ménard's lawsuit, he said, no, it had nothing to do with either one of them. It only had to do with fairness. So that was a good thing. But at the time, Quebec stated that their estimate of the extent of user fees was somewhere between $10 and $50 million a year. So this, alongside with the Auditor General's report, set us up very nicely for the next time that I had to make a decision about the possibility of an automatic penalty that would need to be applied. Meanwhile, let's head west to Saskatchewan. Well, it's east from here, but it was west from Quebec. Saskatchewan was testing the waters on how to get around the Canada Health Act. They had just put forth the Mri Facilities Licensing Act. It came into effect in February of 2016, and it allowed patients and continues to allow patients faster access to an MRI if they pay for the service. And the rule was that the private clinic performing the service could charge any amount that they wanted for a privately paid MRI, but in return had to provide an MRI for a publicly insured patient at no cost to either the patient or the provincial health insurance system. Now, that sounds really fair, doesn't it, on first glance? They actually extended this one-for-one concept of private payment for publicly insured services to more diagnostic procedures, including CTs and ultrasounds, with what was called the Patient Choice Medical Imaging Act. But this raised many alarms, and I'm sure it did for many of you in the room. As you know, as we've been talking about for the last day and a half, queue jumping for these tests and for any ensuing treatment were the most immediate concerns, but there were many more. As you might imagine, to break even, clinics would need to charge private patients considerably more than would normally be reimbursed for an MRI covered by the provincial system. If patients are paying privately, they would have to probably, we estimated, be paying more than double what had been the previous listed rate. Otherwise, there would be no incentive for private clinics to basically provide a two-for-one service. And in fact, recently checking, it's the current rate, going rate for a private MRI in Saskatchewan is about $950. We feared that if clinics were able to charge multiple times the public insurance rate, that it would create pressure from clinic owners on the government then to actually increase the amount that should be reimbursed under the public health insurance plan. And I knew, as many of you know, that there was no evidence indicating that allowing some patients to pay for a diagnostic service would reduce wait times. In fact, by expediting for some private pay patients who may not actually need an MRI or may not need it quite so quickly as a publicly insured patient, it was most likely that some diagnostic imaging capacity would be diverted and consumed earlier and possibly unnecessarily by private pay patients, causing therefore publicly insured patients to wait even longer for their tests. And more importantly, to get to the point, permitting patients charges for diagnostic services contravenes both the spirit and the letter of the Canada Health Act. A patient who pays for their own out-of-pocket for a diagnostic test goes to the head of the queue, regardless of the urgency of their health need. And if the test reveals, as it often does, and those of you who are medical in the room, it reveals sometimes weirdomas that require further investigations or sometimes interventions, the patient then proceeds more quickly to the front of the line for those treatments or further investigations. And in both cases, the person whose health needs may be actually more urgent end up being shunted down the line. The principle of universal access to care is undermined by allowing those who get access on the basis of their ability or willingness to pay rather than those who have a health need. So I made my views known to two successive Saskatchewan health ministers over this period of time, and I made considerable efforts to talk to them and to encourage them to reverse their ways. I saw it as a bad and costly policy, and I hope that we could find a dignified way behind the scenes for them to back down. I'm always a little bit accused of being on the naive side, so as you might expect, this conversation about private pay MRIs became entangled in the discussions about the health accord. Saskatchewan insisted on, as you fairly might understand, that any compliance actions of the federal government required by the Canada Health Act had to be consistent across all provinces in respect to other provinces. And they said, well, if the federal government is not going after Quebec for their user fees, then why are they coming after poor Saskatchewan when we're trying to make sure people get their MRIs? So when they signed a health agreement in 2017, they tried to claim, without any evidence, that they got a deal around MRIs. And in fact, after we signed the deal, I started reading newspaper articles that said, for example, quote, "In a surprising move, the federal government has allowed Saskatchewan to continue violating the Canada Health Act for at least a year," end quote. I was livid when I read stuff like that. And I made my communications team reach out to every reporter who said anything like that to say, that's not true. And if provinces are trying to claim that we're not enforcing the act, they are wrong. The nuance that Saskatchewan was trying to take an advantage of here is that there is this weird lag time. Governments have a lot of lag times, but there's a lag time that exists between when the user fees occur and when the penalties are incurred. So there's first of all a gap between the fees being charged and then when it gets reported, and then months later that there's a penalty. So Saskatchewan used that lag time to make this claim that they were getting a break and that they wouldn't be penalized for a year. They would be allowed to break the Canada Health Act for a year. But the MRI private pay arrangement did and continues to violate the Canada Health Act. It allows people to jump the queue, as we've said. It is illegal and it is inequitable. And we have good evidence now from some data that's come out very recently that it actually doesn't improve wait times, it makes wait times longer. And so as it increases costs to the system and introduces, I think one of the most important things is it actually introduces risk to patients. As you know, unnecessary tests also lead to unnecessary harms or potential harms due to the incentive to conduct those kinds of tests. And so I continue to say, and will say to anybody who asks me about it, that any scheme whose incentive structure encourages more unnecessary tests and puts upward pressure on costs in the public system while allowing people to jump the queue and do nothing to address wait times is truly terrible public policy. Amid all of those discussions, we did manage to reach a health accord agreement with Saskatchewan, and we continued to agree to disagree. So I'm happy to say, though, that the matter was picked up by my successor, Health Minister Jeanette Petitpas-Taylor, and one of the best outcomes of all of that was that on August of 2018, she wrote to provincial and territorial ministers and clarified in one of these ministerial letters that is now part of the annual report, she clarified a diagnostic services policy and affirmed the long-standing federal position that all medically necessary physician and hospital services, including diagnostic services, must be covered by provincial territorial health insurance plans, regardless of whether they are received in a public hospital or in a private clinic. Take note, Quebec as well. She did not accept the premise that because some patients are willing to pay for accelerated access that they should be provided a venue to do so, and by way of that letter she confirmed that any ability to do so would be in contravention of the Canada Health Act. So pay attention, all of us. This policy takes effect in April of this year. But any reporting on this will not begin until December of 2022, and any penalties associated with this will take place in March of 2023. So we should all stay tuned, and it doesn't strike me that it would be particularly hard to find out who's violating the Act in both Quebec and Saskatchewan, and probably elsewhere. Okay, having completely sidetracked our conversation by the story of Saskatchewan, let me now take you back to the end of the 2016-17 fiscal year and the decisions that had to be made about Quebec and British Columbia. Remember, March is the season where the minister, we're in March now, right? March is the season where the federal minister gets to decide what automatic penalties should apply. I knew that there were several references in the press by our friend Monsieur Menard at this time to the effect that he was keeping a close eye on what the federal government was or was not doing in respect of the Canada Health Act vis-a-vis Quebec, but also more generally. And because of the letter that I had written to Monsieur Barrette, and because Quebec had announced already the abolition of their user fees, Monsieur Menard had decided in the meantime to drop or to stay the proceeding of his action against the federal government, but in January 2017 he conveniently had a press release that stated that if the federal minister failed to apply the law as it relates to Quebec, that the proceedings would start immediately again. And, as you know, we were sensitive to the fact that Canada was a party to the charter challenge that was ongoing in British Columbia, and if the federal government was showing that it wasn't going to fulfill its obligations under the Act with respect to penalties on jurisdictions that allowed extra billing and user charges, this would have the effect of weakening the participation of the federal government in CAMBI, but could also weaken BC's defense of its own health insurance scheme. And we knew that the plaintiffs were watching closely carefully to see if there were any inconsistencies in the federal approach. So as we approached decision time in March of 2017, I was determined to enforce the Act. I did not see it as an option. The Act specifies automatic penalties. Maynard was expecting to see action. We were defending the Act in Canby, and our actions were critical. Previous governments had turned a blind eye, but I believe that we were at a critical point in history where the publicly funded health system is at risk and that we have a responsibility to protect it by upholding and enforcing the Act. Now, one of the big challenges of previous governments was that they lacked evidence on which to enforce their automatic penalties. In the case of Quebec, as you'll recall, though, we had the Auditor General's report, and her estimate for extra billing and user fees had a range based on whether the lowest or the highest fees were charged, but even at the lowest, it was about $10 million. And so, in March of 2017, I authorized a Canada Health transfer deduction of $9,900,000. And what made this quiet, but I think somewhat dramatic decision more politically palatable, however, was that given that the province had already committed to eliminate accessory fees, and in the spirit of the Act's intentionally non-punitive objectives, we subsequently made arrangements that the amount would be returned. Now, you have to remember the context of Damien's talk yesterday that, you know, in theory, Quebec had eliminated user fees and specified its commitment to upholding access. So you can take that with a bit of a grain of salt, but in the end, it was one way to be able to move in that direction of penalties. In BC, we didn't have the same clarity, unfortunately. There was audit evidence from 2012 in the public domain. There was an audit of $174,000 of patient charges during 1 week at 2 of the clinics that are operated by Dr. Brian Day. Everybody knew that this was a significant underestimate of what was going on in terms of the total breaches in the province, but nevertheless, kind of amusingly, the $174,000 figure was used as the basis for deductions from BC's Canada Health transfer for every single year from 2013 to 2016. I say amusingly because BC used this figure in its reports to Health Canada in a non-extrapolated form, so everybody knew that this was a 1 week audit of $174,000, and nobody pushed them to extrapolate to realize that for a full year that would actually add up to, at that amount alone, over $9 million. So as minister, I was required to make my own estimate if I had reason to believe that a province was providing an inaccurate report. Extrapolating from that amount to a full year seemed a reasonable way to make that estimate. And of course, I knew that $9 million was presumed to be an underestimate, considering that there were other clinics that were where patient charges were occurring. But essentially, there were insufficient information to know exactly the extent of those charges. And I should just, on a side note, remind you that the British Columbia transfer in that fiscal year was a total of $4.73 billion. And so even if we had charged $9 million, that actually works out to only 0.2% of what their health transfer would have been. Yet, I can tell you that at the very highest levels of political staff, they were very nervous about applying penalties, both in the case of British Columbia and Quebec. But I was adamant. In fact, I looked up last week my email that I sent to my chief of staff, and a few of the parts that are don't include expletives. I wrote, quote, "The Prime Minister's office should know that the Canada Health Act was brought in under Prime Minister Pierre Trudeau, and it is the foundation on which our publicly funded healthcare system rests. This is a law and policy that Liberals have always stood by, and it is entirely in keeping with our commitment to supporting the middle class. Upholding the Canada Health Act is for the good of all Canadians." Quote, again, "Some previous federal governments have gotten away with turning a blind eye because there hasn't been clearly clearly documented evidence of violations to be addressed, but we now have that evidence in case of both British Columbia and Quebec. If we do not act, we will almost certainly be sued by Menard, and we, or I, will look cowardly and weak. It will look like we only do the right thing under legal pressure. The bottom line is that the Canada Health Act is the law, and we have no choice but to do the right thing, end quote. So, suffice it to say, and this is probably a significant understatement, there was much hand-wringing about what to do with British Columbia in March of 2017. In the end, we came to an agreement that we needed better data. We could make an estimate based on extrapolation, but I managed to be convinced by those around me who were trying to make me back off the ledge that it would be helpful to have a new and extensive audit. We did believe that when the federal government testified in the Canby case that it would be helpful, it would give us a position of greater strength if we actually had a record of that was more accurate in terms of the deductions, more closely approximating what was actually going on. And so you can fast forward then, there was a provincial election, and by that summer, as you may know, Health Minister Adrian Dix and I announced that the province's clinics were being examined for potential violations of the BC Medicare Protection Act, which, as we've discussed, mirrors the requirements of the Canada Health Act in the area of user fees and extra billing. Unfortunately, I'd like to be able to tell you all of the details of that audit, but those audit reports can only be released if the minister deems that it's in the public interest to do so. I kind of would argue that it is, but that's kind of beside the point. What I can tell you is that in March of 2018, the Federal Minister of Health at that time authorized a deduction of $15.9 million from the transfer to BC based on the results of those audits and extrapolating them province-wide. And setting aside that deduction reimbursement thing that happened in Quebec the previous year, this was by far the largest deduction from any provincial transfer since 1987. So that was a cool thing. It's not that I, find glory in taking money away from provinces, but, there are rules. So ongoing provincial audits, interestingly, also documented that there were at least 11 clinics that were extra billing in 2016-17, and so that audit was expanded, and in March of 2019 as well, there was a further $16.2 million that was deducted from the transfer to BC. So what's interesting about this story is that even though the Canada Health Act itself hasn't been amended, work like this does allow policy enhancements that strongly benefit Canadians. And as you'll see, and this is well documented by the literature at the time, the goal of enforcing the Act is essentially to incent or to encourage governments to come into compliance with the Canada Health Act. And it's the goal is not to inflict pain on provinces or territories, lest I imply otherwise, but it's to encourage them to change their policies and to comply, as was the case to a greater or lesser extent in Quebec. But we needed some clarification at the federal government around what this policy was so that we could actually have a deduction and then also a reimbursement. Some of you who know the details will know that in the first 3 years under the Act from 84 to 87, there was a mechanism in place because at that time the violations were massive, and so there was an ability to be able to reimburse at that time. So I'm happy to say again that my successor, Minister Philpott-Taylor, followed up on this, and she announced a reimbursement policy so that provinces and territories could have their deductions reimbursed, but only if they had effectively addressed the concerns regarding extra billing and user fees by eliminating those charges. Provinces have 2 years to be able to deal with this, and you might know that British Columbia actually has submitted a reimbursement action plan. It's publicly available in the annual report showing how they intend to eliminate those charges, and they are working as we speak with Health Canada to curb those charges. So I'm going to wrap up my behind-the-scenes commentary by noting again that I think this demonstrates that the Canada Health Act has stood the test of time. Its provisions, including its enforcement mechanisms, continue to for the most part, withstand the multiple forces that seek to erode universal accessible public health care in Canada. So by now you'll be looking at the title of my talk that was Canada Health Act Fold, Hold, or Raise, and you'll have figured out my bias. I am a fan of the Act. Under no circumstances do I think that the Act should be folded. It is one of the key reasons why we have relatively good health outcomes in Canada, using health systems that are comparatively equitable, accessible, efficient, and effective if you look at us from a global perspective. I haven't addressed the possibility that the bar should be raised. Could we do better? Well, of course we could. You'd be hard-pressed, I think, to find any health policy expert in the country that thinks that the Act has lived up to all that its designers intended it to be. And I haven't left much time to go into any detail on how I'd like to see it improved, but let me just provide a few brief comments. We've already had a bit of discussion this morning, in particular around a couple of areas where the Act could be expanded or a variation on the Act could be expanded, including dental care, and of course the strongest momentum at the moment I think has coalesced around pharmacare. I am hugely supportive of evidence-based expansion of Canada's legal framework for healthcare, and like many of you, as it comes to pharmacare, I have a bit of anxiety about where things are going, and as we've already discussed, will it be universal single-payer public pharmacare, or will it be some kind of a patchwork attempt at filling the gaps? My personal bias is that I would fight for the former, the universal single-payer public plan. But permit me to pitch, since I have a platform, 3 other missing pieces that I think there is evidence that we could build a case for expanding the Canada Health Act. In my dreams, I don't know whether you dream about this kind of stuff, but probably some of you do. In my dreams, if we could redesign federal health legislation for the 21st century, and I will note on the side that I would have massive improvements to our public health laws, but that's not exactly the topic for today, although it's relevant in our current pandemic context. I think I would consider at least adding 3 healthcare delivery components under which there should be statutory obligations. And those are, number 1, universal comprehensive primary care, number 2, mental health care, number 3, home care. We know that the Act, and even more so its predecessors, as we discussed this morning, including the Hospital Insurance and Diagnostic Services Act of 57 and the Medical Care Act of 66, they were written in the healthcare context. It's very different. That's in fact older than most of you in the room. A context where care was delivered by doctors and care was delivered in hospitals. In today's context, the biggest drivers, the biggest expenses of healthcare, as you know, are doctors, hospitals, and drugs, comprise 60% of our total spending. Why are we not committed to public funding for the less expensive, evidence-based means of improving health? We have endured chronic underfunding for interprofessional primary care, mental health, and home care, leading to inefficiency and avoidable suffering. And so my plea to you is to consider how we might better advocate for these areas of care to be brought under the umbrella of statutory obligations for universal health coverage. And this leads me to my very final brief comments, and that's on the importance of advocacy. This room is full of law and policy experts, clinicians, academics, teachers, and researchers. I hope you also see yourselves as health policy advocates, because it is, I think, an important part of your professional success, but also our collective best interests. I don't have time to give a pitch for all the effective ways of advocating, but suffice it to say that you should not remain quiet. Find ways to make your voices and make the scientific evidence heard. Write opinion pieces for every publication you can get yourselves into, collaborate, publish in the academic literature, stay active on social media, get active on social media, grab hold of whatever platforms and spheres of influence are open to hearing your views. Join a political party if you're so inclined and make your policy expertise known in that context. Run for office, please. Some of you, we need you. I hope there's a future health minister in the room. The health of Canadians depends on ensuring that our health systems remain fair and accessible. So hold fast. You have a big role to play in the nurturing and improving of the future of healthcare for Canada, and your work is absolutely essential in our collective pursuit of health for all. Thank you very much. Chi miigwech.